Okay, wanted to say thank you, everyone, for joining us this evening. I hope everyone's doing well. We will be recording this lecture and sending it out to everyone who is registered. Today's community lecture will be given by Dr. Willie Gonzalez. Dr. Gonzalez is a board-certified fellowship-trained sports medicine physician. He obtained his doctorate of osteopathy from Philadelphia College of Osteopathic Medicine and followed with a residency at the Family Medicine at Lehigh Valley Health Network Family Medicine. There, he was chief resident and was awarded the Resident Educator of the Year award. Dr. Gonzalez followed with a fellowship in non-operative sports medicine at Thomas Jefferson University Hospital. During this time, he served as the assistant team physician for high school, collegiate, and professional teams, including the Philadelphia Phillies and Villanova University. He also participated and cared for Major League Baseball prospects during the 2001 International Combine. Dr. Gonzalez is committed to research and education and has presented at a national level through the American Medical Society for Sports Medicine, pertaining to adolescent and collegiate athletes, mental health, and concussion management. His clinical interests include degenerative conditions such as joint, tendon, muscle, and ligaments, as well as overhead throwing athletes, sports-related concussion management, running athletes, dance medicine, and overall comprehensive health of physical athletes. He is trained in ultrasound-guided procedures for chronic degenerative conditions. His experience in family medicine trained him to have a comprehensive approach to patient care, allowing him to treat patients as a whole. He is fluent in Spanish, allowing him to better accommodate our Spanish-speaking community. Dr. Gonzalez sees patients in our Tarrytown location, which is at 658 White Plains Road in Tarrytown, New York. He is there on Tuesdays. He also practices at our Harrison office, which is located at 450 Mamaroneck Avenue. He's there the rest of the week. The topic for tonight's lecture will be shoulder and knee pain, more common as we age. If you have any questions throughout the lecture, you can type them in the question and answer section at the bottom of the screen, and Dr. Gonzalez will answer them at the end of the presentation. Now I turn this over to Dr. Gonzalez.
All right. Good afternoon, everyone. Thank you for coming and being a part of this. John, thank you for that wonderful introduction. It's very comprehensive. I just want to start, mentioning a little bit about some of the things that, maybe John didn't mention, just some of the specifics that I do in the office and sort of outside of the office. So like he said, my main specialty is primary care sports medicine or non-operative sports medicine. So essentially what that entails is all of the steps before having surgery, which are many. That's sort of where I specialize in, getting you back on the field or getting you back into playing tennis or pickleball or baseball, whatever it is that you are interested in sort of continuing to pursue. My goal is to get you there and hopefully doing that without any surgical intervention. Of course, if you require any sort of surgery or procedure, we can always have you see the right individuals as well. So, again, my specialty entails all of this. I do ultrasound guided injections and procedures in the office. I also manage concussions as well. And as he said, I was part of the Phillies organization prior to, sort of starting this position at Rothman. And currently, I'm the team physician for the New York Empire Ultimate Frisbee team. So the agenda for today, we're going to, kind of get a little bit close and personal with some of our anatomy and kind of understand a little bit about the shoulder and what's in the shoulder and a little bit about the knee and what's in the knee. We'll talk about some common causes of both of them as well, some common causes of pain. The idea of when to sort of seek out one of the physicians at Rothman and have a conversation with them about what's going on and the pain that you're having. And then, how to stay active, certain exercises that you can do at home that oftentimes help to really sort of strengthen and keep you, flexible and things like that is, oftentimes, the things that you need just to kind of keep yourself healthy and moving. So those are all the things that we'll talk about today. So just to start off with the shoulder anatomy, the first one will be the deltoid muscle. So the deltoid muscle is sort of that top bulky muscle that everyone sort of sees or gives shape to your shoulder. Okay, it's the strongest muscle in the shoulder. It is the least common muscle injured, so oftentimes patients will sort of point to that area of the deltoid that causes shoulder pain, but it's a lot of the stuff that's underneath that oftentimes gets injured or irritated. And it really helps with sort of all range of motion with your shoulder. If you peel that away and underneath, there's some other structures here. So this is the front of the shoulder. If you take a look, the shoulder or the muscle that is kind of coming down your arm from the front is your biceps. So your biceps, interestingly, is called biceps just because it has two tendons. And one of the tendons sort of reaches and attaches to what's called the acromion or the coracoid just before your shoulder. And then there's another tendon that actually goes all the way and attaches to almost the top portion of your shoulder. So sometimes you can have pain in that area, in the front of your shoulder, and it can actually be your bicep. There's another structure sort of on top of that that's called the bursa or the subdeltoid bursa or the subacromial bursa that oftentimes, sort of sits there, sort of a balloon-like structure that can help muscles glide between each other. And sometimes that can also be, a location of pain or irritation. The back of your shoulder shows the rest of your rotator cuff muscle. So you have the supraspinatus, which is a muscle that sort of sits just at the top and a little bit behind your shoulder that comes down into the outer portion of your shoulder. There's another muscle right underneath it called the infraspinatus. And then there's a teres minor muscle and a teres major muscle. So as you can see, the idea here is not to obviously memorize all these muscles, but to sort of understand that there are multiple muscles that are pretty small that all contribute to the motion of your shoulder. The triceps, sort of that bigger muscle in the back of your arm, it also contributes to potential pain and discomfort, however rare, but it can contribute. So what are some common causes, right? What are some of the common things that we often see in the office that causes shoulder pain? So the first one here is shoulder impingement. And, impingement oftentimes refers to, the structures in the shoulder sort of being compressed. And oftentimes they're compressed between two different structures. So the clavicle, oftentimes patients don't realize that the clavicle actually goes all the way out to your shoulder. So that hard sort of bony surface, sort of ends at what's called the acromion. And every time you kind of lift your arm or lift your shoulder, excuse me, you'll have those muscles that sort of get impinged just slightly underneath that clavicle or acromion every time you lift your shoulder above your head. When you do that, if you do that occasionally, obviously these muscles can sort of take that. There's no real issue. You're not going to get inflammation, when you do that, sort of on a regular basis. But if you do some sort of activity that you're not used to, for example, you decide to paint your living room and you're sort of, painting over your head for a long period of time, or you decide to pick up gardening and, you're sort of, kind of on your knees and kind of getting into the weeds a little bit in terms of, the dirt and everything. If you're not used to something like that, the muscles underneath, after doing it for a long period of time, can start to get a little bit inflamed or irritated. That bursa that you see in the picture in the middle can get inflamed as well, and can get swollen, and oftentimes that can fill up with a little bit of fluid. And when it does, then that causes pain, it causes irritation. It can make it more sensitive for you to move your shoulder. So that often is a very common cause of shoulder pain. Now, another common cause of shoulder pain is a rotator cuff tear. You just sort of tear a tendon or tear a muscle. This oftentimes is more sudden activities, not so often sort of repetitive overuse, but this oftentimes can be, you're picking up a grandchild, or you're picking up your son or your daughter, and you do it quickly and you feel sharp stabbing pain suddenly. Sometimes that can really be that tendon that can tear. Or you're, on the golf course and you do a really hard swing and you accidentally hit the ground, or your swing is just a bit off and you get a sudden pain. Some of the more common things is, patients just happen to trip and they try to catch themselves with their hands, and, they'll suddenly sort of grab onto a wall or something that they're able to grab onto, and just that force can sometimes really cause a rotator cuff tear. Another common, cause of shoulder pain is arthritis of the shoulder. This is usually more, genetic based. You have a family history of arthritis. This is a gradual sort of onset. Oftentimes patients will say, I feel clicking or grinding. My shoulder feels really stiff when I wake up in the morning. Oftentimes these are sort of the symptoms that can happen with this. Something else that can cause arthritis in the shoulder is if you've had, a fracture in the shoulder, or, a fracture in your arm, sort of higher up within their shoulder, that can sometimes predispose patients to having some arthritis as well. So how do we sort of prevent shoulder injury, right, or damage? So the reality is that the best way to prevent, tearing of the rotator cuff, or, some of these impingement symptoms, is a combination of flexibility and strength. So if we strengthen your rotator cuff, it'll be less likely to tear. If you're more flexible, you're less likely to cause any form of impingement or compression. So these two exercises that you see here, I really like, because it really helps sort of stretch out the shoulder and stretch out the rotator cuff. So the first one with the gentleman with the blue shorts, this one really helps to sort of get a lot of those, muscles that will sort of pull your shoulder downward, like some of the back muscles, like your lats, to kind of stretch a bit, so you have, a little bit more range of motion. It also helps your shoulder sort of get used to being in that position. Usually I recommend, if patients are interested in doing these exercises, they can usually do it, 2 to 3 times per week. The door stretch is a great one as well. Commonly, we're all sort of hunched over on computers, so the muscles in the front of our body can get pretty tight. So, grabbing onto a door, sort of like this gentleman here in the white pants, and sort of just leaning forward and stretching some of those muscles in the front, some of your chest muscles, really help sort of open up those shoulders and keep you flexible. Now, these 3 exercises are also fantastic for the rotator cuff. So I often recommend to my patients to get some bands at home. This doesn't have to be heavy bands or any bands that are really, really, hard to use. Just some light bands that can kind of help you get a little bit of an exercise. So, putting it on something to kind of anchor the band, and then pulling back with the first exercise can really help get some of those back muscles nice and strong, to help open up your shoulders a bit. The exercise in the middle to sort of push away like that, that can help some of the rotator cuff muscles that are in the back of your shoulder. And then that last exercise all the way on the right is working on some of the rotator cuff muscles that are in the front of your shoulder. So these also I often recommend in combination with the stretching exercises with these. To often recommend them to do 2 to 3 times per week, just to kind of keep your shoulder nice and strong, nice and flexible. Oftentimes, just these exercises can actually help really reduce some injury. So when to make an appointment, right? Injuries happen. It is what it is. Oftentimes, sudden, sharp, stabbing pain with difficulty really doing any sort of daily activity. That's when I'll tell patients, if it's really bothering you that significantly, you should come in and have one of our physicians take a look at you. In terms of weakness in the shoulder, so weakness is definitely concerning. If you can't lift things the way that you used to, definitely come in and see us. Reduced range of motion, if you can't kind of lift your shoulder or lift your arm above your head, also concerning, or something that we should sort of evaluate in the office. And then any subtle pain that's really just lingering, often lingering pain for more than 2 weeks is something that probably isn't going to go away on its own. And I often recommend that you see a physician and see what we have to offer in terms of any anti-inflammatory medication, or if there's something else going on. And then sort of the red flags that I often tell patients: if you're having trouble sleeping because of the pain and you've had days where you just can't get to sleep, we all need sleep. It's very, very important. Sleeping or not sleeping can actually worsen symptoms, right? We get cranky, a lot of that stuff. We get pretty tired. That can actually exacerbate the way that we feel. So definitely important to see one of our physicians if the pain is keeping them from sleep. So how do we treat shoulder pain, right? There's a lot of different modalities that we can do, or that I sort of manage patients with. On the conservative treatment side, right, there are home exercises that we talked about, anti-inflammatory medications, all different kinds that we can discuss. There's specific physical therapy, occupational. We can, provide things like a sling for the shoulder. There are injections that we can consider, like steroid injections to help reduce inflammation. There's platelet-rich plasma, which is, sort of a specialized injection where we use your own blood to try and regenerate tendons. There's needle tenotomy, which is another procedure in the office, all other kinds of ultrasound guided injections. And then acupuncture and chiropractors. That's not something that I necessarily do, but oftentimes it would be a good idea to kind of get my advice as to kind of whether this would be helpful for you. And then in terms of the surgical treatment, there are surgical treatments that can be considered, right? There are options for that as well. But ultimately, when you come and see me, my goal is to evaluate you and see, what we can do to keep you out of surgery. If you need the surgery, we'll absolutely have that done for you. But the goal here is to kind of keep you moving and hopefully avoid any surgical management. Okay, so let's talk about knee and how to prevent some knee pain here. Let's talk about a little bit of the anatomy. So on the left screen, you'll see, the knee is made up out of your femur, which is the sort of big thigh bone here, and the patella, which is your kneecap, and then the tibia, which is sort of your shin bone. All right. And there are 4 major ligaments within your knee. All right. There's the outer ligament, or the lateral collateral ligament. There's an inner ligament, or the medial collateral. And then their ACL and the PCL, which is sort of inside of the knee that you can't really see. So these are all designed to really support your knee structurally. They're all really, really strong. Do a great job at really holding the joint together. The other thing that really helps with cushioning of the knee is your meniscus. You have 2 meniscuses, essentially one on the outer portion and one on the inner portion of your knee. And they're basically like cushion. They're sort of rubbery, cartilaginous, similar to a feeling of almost like your ear, that sits sort of between the 2 big bones there. and really help support, that cushion aspect of your knee. You can imagine, your knee does take a significant amount of weight, just because it has to hold all of your weight. And then the fibula, which is that smaller bone sort of on that outer portion, is one of the other bones that technically is part of the knee joint. Doesn't do a whole lot for the knee, but it is something that, is part of the joint complex. So what are some common causes of knee pain? So the first, probably the most common cause that I see is patellofemoral pain. Now, what is patellofemoral pain? So oftentimes this is sort of a combination of things that causes pain. It's an irritation of essentially the kneecap or behind the kneecap. Okay. It's a combination of some imbalances within the muscles that support your knee. Definitely a little bit of overuse, or if you sort of ramp up too quickly. Okay. Oftentimes it's a combination of some of their ergonomics as well. If you can see that gentleman with the purple shirt, the way he's sitting, not ideal. Puts a lot of stress on your knee, crossed like that, and probably on your back too. But that combination oftentimes can create some discomfort in the front of the knee. The kneecap is one of those bones that, ultimately sits sort of in between two large tendons. So it's somewhat free moving. And oftentimes it can sit, inappropriately within the groove, for whatever reason, whether it's again from overuse or from, certain positions that you place the knee. And oftentimes that cartilage behind the kneecap can get pretty irritated. Meniscus tears. This is more sort of sudden injuries. Okay, so oftentimes this occurs with sudden turns, whether you're playing basketball and you try and make a quick cut, or you are getting out of the vehicle and you try and get out of the vehicle quickly and you kind of make a step and twist. Sudden jumps, things like that can oftentimes cause meniscus tears. The common thing with this is that you'll have swelling pretty quickly, usually within a day or two. If that onset of pain occurs, you'll have a fair amount of swelling. Oftentimes that could be your meniscus. Oftentimes it's a sort of a rotational component of things that will cause it. But it can still be some of those sort of direct things. I've seen patients tear the meniscus, by just kind of taking a misstep from, walking downstairs. So it's still possible. If you get some swelling, it's definitely something that we should have evaluated in the office. Now, arthritis in the knee, oftentimes I get this question. So what really is arthritis? So arthritis is essentially a wearing away of the cartilage, okay, within a joint. And once that cartilage wears away, then the bones start to sort of rub into each other. And that's sort of the progression of what arthritis is. Oftentimes, you'll get a nice visualization of the knee on an X-ray. As you can see on the left side, there'll be sort of nice black space sort of in between the two bones. That's what we're looking for. We're looking for a good space. There is no real space there. The meniscus sits in there, but you just can't see the meniscus on an X-ray. So, when arthritis starts to set in, some of that cartilage starts to wear away. You start getting sort of cracking or degeneration of that cartilage or thinning of that cartilage. And once that cartilage fully thins out, then you'll start to see on X-ray, sort of the bone on bone, there won't be any space. Oftentimes it can be quite painful. You'll get swelling with this as well. This is a slower onset, right? You'll have pain like this for, weeks or months, and it just doesn't get better. Or, you get sort of a dull, aching, bruising sensation that oftentimes bothers you at night. But that's more typical of arthritis. You'll also sort of wake up, and oftentimes when you wake up, you'll be really, really stiff and have some difficulty with the first couple of steps. And once you kind of get moving, you feel a little bit better. Those are more typical signs of knee osteoarthritis. Oftentimes, anti-inflammatories are really helpful for this just because this is an inflammatory condition. So, really trying to reduce inflammation is sort of the key here. And then attempting to strengthen again, the muscles that surround the knee is really the most important portion of this. Now, tendonitis, right? So you can get inflammation of some of the tendons around the knee as well. Some of the more common causes or some of the more common tendons. The gentleman, holding his leg here, that's the hamstring tendon. So you have hamstring tendons behind your knee. Oftentimes these can get pretty strained if we increase activity quickly, that kind of stuff. The patellar tendon, as you can see on the image on the right, that oftentimes can occur if we're sort of doing a lot of squatting or, we've been working with our knees bent for a significant amount of time. Let's say we are changing the tiles on our floor in our apartment and we've been working on that, that could cause a lot of discomfort in the front of the knee and can potentially stress that patellar tendon as well. This is an inflammatory issue as well, so oftentimes anti-inflammatory medication is really helpful for this. But again, if these sort of inflammatory conditions like this tendonitis sort of lingers for more than 10 to 14 days, it's really important to consider seeing one of us to evaluate kind of what's going on, because there could potentially be a partial tear of some kind. So how do we prevent, knee injuries, right? So as all these lovely people here are exercising, the key here is to continue to exercise as best as you can without causing injury. The stronger and more flexible that you are, the better. So these exercises I really, really like for strengthening the knee. And ultimately, these are actually strengthening a lot of the muscles in your thigh and in your glutes. The reality is that a lot of these muscles, really help to change the mechanics in your knee. So that's the key here is the stronger that your core is, your glutes, your thighs, the more, the more well balanced or the better the mechanics will be in your knee to prevent any injury. So the first exercise is often called clamshells. Those are fantastic to really help strengthen some of those glute muscles. Okay, the one in the middle is just sort of side leg raises. That can really be helpful to strengthen some of the glute muscles and some of the thigh muscles as well. And then that last exercise on the right is also helpful to help with some of the core muscles and some of the back muscles that can support your pelvis. So those are all really good to help with strengthening and kind of keeping knee pain at bay. So again, when to make an appointment for this. So sudden severe knee pain with swelling or difficulty walking, very important. If you have sudden swelling, to come see one of us to figure out why that's sudden. Anything that's progressively worsening, it's not getting better, usually greater than a week of pain within the knee, probably a good idea to kind of have us take a look. Any injury that causes swelling. So if you have a significant injury and it suddenly swells and you can't walk, that's definitely a reason to come see us. And then any sudden bruising or redness in the skin, surrounding an entire joint, there's a potential for infections within the joint, things like that, we can definitely take a look at. And how do we treat it? So a lot of the similar things with the shoulder, right? Exercise, physical therapy, platelet-rich plasma, steroids, and ultrasound injections. There's bracing, there's trigger point injections that we can do. The one thing that we can consider with knee issues or with knee arthritis in particular are gel injections. That's something that, is something that we can definitely try if cortisone shots don't help. And then we can always drain your knee. Oftentimes that fluid that builds up within a knee can really cause a lot of discomfort. And then again, there's lots of surgical, treatments for this as well. But, hopefully we can get you, kind of feeling a whole lot better without really, talking about any surgical treatments. So what are some key takeaways? So, never stop exercising. That's really the key here. If you want to go for a walk, go for that walk. Just pay attention to the amount that you're walking and be consistent with it. Don't dramatically increase. you want to play with your children or grandchildren, do that. Continue to kind of stay active. Play your favorite sport or pick a hobby that allows you to kind of keep moving. Gradual build up into activities is really what is really important here. Gradual movement. Nutrition is very important as well, right? Making sure that you're having or that you're eating a well balanced diet is always very important just to help strengthen muscle and strengthen bones. And then, conservative management is broad. There's lots of options, aside from immediate surgery. So having one of us evaluate you is important. I want to thank everyone for participating and just really listening to me talk. This is my dog. He likes to dress up. He's a Yankees fan. His name is Bronx. And thank you, everyone, really.
Thank you, Dr. Gonzalez, for that very in-depth talk. I do have a few questions for you that some of the participants have left us. First question is, what type of shoulder injury will cause pins and needles in your fingers?
Yeah, so oftentimes pins and needle sensations, sort of that start within the shoulder can often be, part of the neck or can originate in the neck. Okay, there's oftentimes it can be a lot of muscle tightness. So if you have some pain that radiates into the neck, that can cause a lot of muscle tightness that can actually compress some of the superficial nerves and cause that sensation. That's commonly, what can occur. There are certain things that can cause impingement of nerves in the shoulder, but they're pretty rare. So if you're having, pins and needles that are kind of radiating downward into your hand or into your forearm, the first thing that we definitely think about would be, let's take a look at your neck. We can get x-rays of your neck and then get x-rays of your shoulder as well and really evaluate comprehensively and figure out where this is coming from.
Great, thank you. Another question we have is concerning the knees. Are 50 squats a day good for the knees?
So it's relative. So if you have been doing 50 squats a day for a year or two, and that's something that you are comfortable with, sure. The point with exercise is that it's gotta be gradual. So if you have been doing no squats every day, I wouldn't recommend going straight to 50. Potentially doing 10 to 15, and then maybe 24 to 40 hours later doing 10 to 15 again, and then maybe doing that for a week, and then gradually sort of building into 50 if that's your goal. That's the key. That's really the idea here. Is to kind of continue to keep yourself active without any injury. So I hope that answers your question.
Great, thank you. Next question, is taping good for the knees, and when should it be used?
Yeah, so taping can be helpful, to help with some of the certain muscle discomfort and things like that patients can have. We've done a lot of studies on taping and kinesio taping, and some individuals find it extremely helpful. The good news is that we haven't found any detriment. So, there isn't any sort of downside to taping. If you find it helpful, continue to do it. It's, there is no sort of negative effects to it. So I ultimately it's sort of dependent on the individual as well.
Great, thank you. Next question. Deliberating pain behind the patella developed to the point where going up and down stairs is excruciating. The walking is okay. I'm assuming it's arthritis. I'm 56 and have had pain on and off since my 30s. It eased up, but I'm assuming it will be back. Is this normal?
So pain is never normal. But I agree with you. If you're having a lot of pain and discomfort going up and down stairs, and you're okay with walking, oftentimes going up and down stairs really stresses that sort of joint or that cartilage behind your kneecap. So it could be arthritic change. I'd really be interested to know, sort of what's going on. We would get an X-ray and take a look and see if there's any, sort of joint changes that could tell us that. Um, but it's possible. It could be arthritis. It could be inflammation of the cartilage. That kind of stuff. The exercises that I pointed out on my lecture can be helpful with that. But if the pain, is sort of consistent and has been going on for quite some time, I often do recommend that you come and see me.
Great, thank you. Next question is, what is the best over-the-counter safe meds to take for pain in the knee that you
Yeah, so
recommend?
yeah, absolutely. So really the safest one that I often tell patients, just because it does not sort of become a systemic absorption, is diclofenac gel, or what's commonly, now branded as Voltaren gel. That's a really good medication that I often recommend just because you can apply it exactly where it hurts. And it does absorb through the skin. So you could apply it, 3, 4, even 5 times a day if necessary. Uh, Oftentimes that's the best one in terms of safety, that I often recommend to many people.
Great, thank you for that. Next question, can my neck pain be related to my shoulder pain?
Absolutely. Yeah. So oftentimes you can get a combination of either shoulder pain radiating into the neck or neck pain radiating into the shoulder. Oftentimes I do recommend that you try some stretching exercises, like I mentioned, things like that for the shoulder. But, if it's not helping with the neck pain, then, we should definitely figure out why you're having neck pain, especially if it's been going on for longer than 2 weeks. Sometimes we can figure out whether it's a muscle strain or some arthritis in your neck or something like that's causing your pain. It's always a good idea to kind of have us take a look.
Thank you. Going back to that last question, the participant asked, sorry, could you repeat the name of the pain gel? Was it Voltaren that you mentioned?
Correct. Yeah, Voltaren 1%.
And that's over the counter, correct?
It is over the counter. Yes.
Perfect. Lidocaine patches, good or bad?
Um, Good. I think they work fine. Lidocaine patches were designed more for sort of nerve pain. So, if someone finds it to be helpful, that's okay. That's fine, but it won't necessarily help with joint pain. So, oftentimes patients will say, I use a lidocaine patch, it didn't do a whole lot. It doesn't surprise me. That usually requires something a little bit different, like an anti-inflammatory or something else if it is a joint or muscle issue. Um, but lidocaine patches can help take sort of the edge off a bit. So, they're not completely, bad for you in any case. Just, don't go around putting lidocaine patches all over your body because that'd be too much.
Okay, thank you. Next question, do you recommend physical therapy with a rotator cuff tear?
So it depends. It depends on the severity of the rotator cuff tear. Oftentimes, we do recommend physical therapy with sort of partial tears. You're not someone that is prepared for surgery. Most individuals do get better with an extensive course of rehab and therapy. So if it is a partial injury, yeah, I think physical therapy is definitely helpful. Um, but it does depend. I have seen patients come into my office and I'm really worried about, complete tears of the rotator cuff or large tears. And I often recommend them to see a surgeon, just because of the severity and the extent. So ultimately it depends, but if it is a minor, tear and you're still using your shoulder quite well, then yes, the physical therapy, couldn't hurt.
Great, thank you. Next question, will particular type of shoes or inserts help with knee pain? Example, realignment?
Absolutely, yeah. So I often, when I see you in my office, if you're having knee pain, I will often ask you to take your shoes off or, take a look at the way that you're walking into the office because it all is connected, So if you have flat feet, for example, that could definitely contribute to the angulation or the mechanics of your knee and can definitely contribute to knee pain. So, I've had many patients where they'll come in for knee pain and they'll walk out of my office with an orthotic of some kind, to kind of help support their foot arches. So yes, definitely, orthotics is something that I've used for knee pain. But it'll depend on my evaluation for sure.
Great, thank you for that. Next question. With moderate knee pain, what activities should I avoid? I run 3 to 5 miles a day, ski 5 to 6 times in the winter months, and swim regularly.
Yeah. So you're pretty active, which is fantastic. But if you're having moderate knee pain and your activities are exacerbating this, there's something going on, right? So if it's been going on for quite some time, for longer than 2 weeks, always a good idea again to have us take a look and just kind of reassure that things aren't worsening or that you're potentially creating a situation where things can get worse on you. Um, if an anti-inflammatory oftentimes makes it, just go away, that's a good sign. But if it continues to come back, um, we should take a look at least, to make sure that the activities that you're doing, are safe.
Great, thank you for that. Next question. Can you explain the difference between the gel injections you mentioned versus the steroid injections?
Yeah, absolutely. So steroid, I often tell patients it's a really strong anti-inflammatory. Okay, so it's sort of the fire extinguisher is what I like to sort of tell patients. If you're having a full-fledged fire in your knee, the pain has just been constant for weeks. Um, you're having some difficulty sleeping at night here and there just because of the knee pain. Excuse me, or you've had a significant amount of swelling. Cortisone is fantastic to really reduce those symptoms because it can really reduce inflammation within the knee. Now, a visco supplementation or a gel injection, more designed for sort of that simmer. You have a little bit of discomfort. You potentially have a little bit of degeneration in your knee. The cortisone injection that you got potentially didn't help as much as you would have liked. That's where gel injections come into play to kind of increase some lubrication within your joint, and hopefully, kind of give you some relief. Now, what I'll mention about gel injections is that, it's often a series. So it's not just one injection, and it is usually more than one. It's three almost always. It depends on the brand, but it's usually three, and we do it in a series. Do one, and then we do the following on 1 week intervals. Um, Oftentimes patients do find some improvement with it just because of the help with that lubrication of the joint. And the gel itself is what's called hyaluronic acid, meaning it's something that the body produces. So side effect profile, is actually quite low.
Great, thank you for that. Next question, is KT tape good for the knee?
Yeah, so KT tape, I assume that KT tape was what taping was the last question, but yes, so it can be. There's no downside to it. The good news is that's there's no downside. We've done studies on it, and we really evaluated to see if whether patients find it very helpful or not. Some patients do, some patients don't. But again, as long as you're not allergic to the adhesives or the tape itself, continue to use it. There is really no downside to it.
Okay, great. Next question is, I have been suffering from knee pain since 2018, had tear in my meniscus, and since surgery have been getting gel shots such as Monovisc. These gel shots last about 3 to 4 months. After that, the pain is excruciating and I'm at wit's end. I just visited Dr. Chang in the Madison Avenue location, but now my other knee is now giving me the same pain. Hurts to even get up and down from a chair. Pain is a 9 out of 10. Not sure what can I do at home not sure what I can do at home to help me. I will be doing those you shared in your presentation. Any other suggestions? Since I am a very active person lately, the pain has stopped me for the last 4 months of even working out.
Yeah, I'm sorry to hear you're going through so much pain. If the pain is 9 out of 10 and it is on the other knee that has not been evaluated, we should definitely evaluate. 9 out of 10 pain is pretty high, and if we want to keep you active, we should really act in terms of what to do for you. The other thing that I'll mention is that if cortisone did not necessarily help you in one knee, it does not necessarily mean that it won't help you in the other. So we can always think about, again, sort of that full-fledged fire that's going on in your knee, which is what it sounds like. It could be, potential for a cortisone shot to really give you some relief and some help. And then I'll mention in terms of the knee that you've had multiple gel injections on. If the gel injection, really start to stop working after, 5 to 6 months or so, which it sounds like they have, then there's a potential for a discussion about whether you need a surgical intervention, of some kind, whether, a knee replacement may be something that would really bring you some relief. I know it's a major surgery, but again, the goal is to keep you active and to keep you moving. Many patients find amazing relief with a knee replacement. So.
Okay, thank you. And our final question here, and I do apologize because I'm not familiar with this term, so I will spell it out for you. I don't know if it's, a term or if it's something that's misspelled here, but anyway, hopefully you'll be able to figure it out. SOAR, and I'll spell it MATATARSALS. Are feet affecting knees? Any suggestions?
So metatarsal bones.
Okay.
So sore metatarsal. Yeah. So oftentimes metatarsal bones or soreness within the foot can contribute to knee pain. It's not usually the other way around. So if you're having pain in your foot, I definitely recommend that you come in and see us because it's likely not the knee. And then pain, if you're having in the area of the metatarsal, depending on which metatarsal, whether it's like your first big toe, there could be some inflammation in some of those joints as well, that we often can really improve the pain with certain soles or certain types of soles that will provide, or even an injection in that area. So, if you're having pain in that area, in the metatarsal area, it may not necessarily be the knee that's causing it. Oftentimes it's the other way around.
Great. Thank you for all of your suggestions and for answering all the questions. And I'd like to thank everyone for joining us this evening. For more information, or if you'd like to make an appointment with Dr. Gonzalez or one of our other providers here at Rothman, you can visit us at rothmanny.com, or you can call 914-580-9697. And just a reminder, we'll be sending out a recording to all the registrants within the next few days. And again, thank you very much for joining us. Have a great evening and be safe. Take care.
Thank you, everyone.